Hello, esteemed colleagues and physicians. My name is student Dr. Harrell, and I'm a second-year medical student at the Idaho College of Osteopathic Medicine, working under Dr. Adam Schatz from the Idaho Urologic Institute. In this video, we will explore the enigmatic realm of interstitial cystitis/bladder pain syndrome, which we will refer to as interstitial cystitis, and shed light on the American Urologic Association, or AUA guidelines, that serve as our compass in managing this complex condition. As primary care physicians, you are the frontline warriors in patient care, and understanding the latest recommendations is crucial in the management of this condition. But first, what are the AUA guidelines, and where do they come from? The AUA guidelines are like a blueprint to guide the construction of the diagnosis and treatment of urologic chief complaints. Common recommendations are reevaluated with new scientific literature to ensure we provide the most current, evidence-based care to our patients. As we discover more about interstitial cystitis, we continue to update the guidelines. To begin, we'll discuss the pertinent anatomy and physiology related to the urinary system and delve a bit deeper into the potential pathophysiology of interstitial cystitis. The kidneys are important organs within the urinary system that have many functions, but since interstitial cystitis does not affect the kidneys, we will keep our discussion focused on the bladder. Working our way from the external layer to the internal layer, the adventitia of the bladder provides anchoring support and protection to maintain the integrity of the organ. Moving inward, the muscular layer is responsible for contracting and relaxing to expel urine from the bladder during urination. The submucosa lies interior to the muscular layer, which provides support to the mucosa. The mucosa is the innermost layer of the bladder that is in direct contact with the urine and contains transitional epithelial cells. These transitional epithelial cells stretch as the bladder fills with urine. Ultimately, the etiology of interstitial cystitis is not well understood. It is theorized that in some patients, IC is a secondary disorder to another underlying chronic pain condition like irritable bowel syndrome or fibromyalgia. In other patients, it appears to be their primary condition. The key to treatment of any patient always starts with a thorough HPI and physical examination. To better understand the clinical presentation of a patient with symptoms of interstitial cystitis, let's take a look at a clinical case. Mary is a 52-year-old female who presents to your clinic with complaints of chronic pelvic pain, frequent urination, and discomfort during urination. Mary describes her pelvic pain as constantly dull, but occasionally sharp. This pain is exacerbated as her bladder fills and temporarily relieved after urination. She has burning and discomfort during urination and frequent urination that disrupts her sleep. She sometimes experiences a strong, sudden urge to urinate, leading to close calls. These symptoms have been ongoing for several months and have significantly affected her quality of life. She has tried Kegel exercises with no noticeable improvement. If you see on your daily schedule a patient with a chief complaint similar to Mary's symptoms, you'll start to form a differential diagnosis and ask yourself some questions. When did it start? What is their medical history? And what medications are they taking? By now, you have a list of differential diagnoses: urinary tract infection, sexually transmitted infection, overactive bladder, diabetes, prostate problems in men, bladder cancer, kidney stones, pelvic floor dysfunction. The list goes on. Interstitial cystitis can be tricky and deceptive because it can present similarly to all these conditions, but it should always be on your list of differential diagnoses. Nonetheless, every other diagnosis should be ruled out before concluding that the problem is interstitial cystitis. Generally, patients with interstitial cystitis experience urinary urgency, frequent urination, or pain with sexual intercourse. The main characteristic of the pain that interstitial cystitis patients experience is painful urgency that is relieved with urination. Suprapubic pressure and pain, rectal pain, and urethral pain are presentations of pelvic pain syndrome. Keep in mind that the composition of symptoms varies from patient to patient, and these symptoms are vague. Now that we have reviewed the common symptoms of interstitial cystitis, we can see that many of Mary's symptoms coincide with this diagnosis. The challenge lies in deciphering the true nature of her condition. Like a detective, you must investigate. But where do you start? Let's continue with her case. Mary's past medical history includes irritable bowel syndrome since she was 20 years old, but she's never been treated for it. She experiences diarrhea and abdominal cramps distinct from her urinary pain, and her gastrointestinal symptoms sometimes occur separately from her urinary ones. Mary has had recurrent urinary tract infections for the past 3 years, treated with antibiotics. Her last 2 urine cultures were negative, but she was empirically treated for symptoms. She had 2 uncomplicated vaginal deliveries with no surgery. Mary is currently married with 2 children, and she experiences irregular menstrual periods. Her last menstrual period was about 6 weeks ago. She is sexually active with her husband and has no STI history. She denies recreational drug and tobacco use, drinks 1 to 2 glasses of wine weekly, and maintains a balanced diet with occasional takeout. She aims to exercise daily, though her symptoms hinder this. There's no family history of urinary or bladder disorders. The first step in diagnosis is to define, characterize, and record the patient's baseline symptoms to determine the consistency with the criteria of interstitial cystitis. IC is a chronic disorder, and symptoms should be present for at least 6 weeks with documented negative urine cultures. The physician should be responsible for documenting the number of voids per day, sensation of constant urge to void, and the location, character, and severity of disorder. Frequent voiding with low voided volumes is consistent with interstitial cystitis. In order to establish diagnosis and provide a baseline to measure treatment effectiveness, researchers have used the Genitourinary Pain Index, Interstitial Cystitis Symptom Index, or Visual Analog Scale. It's important to be mindful of menstrual symptoms in women and its effect and correlation with pelvic pain, as well as dyspareunia, dysuria, and dysorgasmia in men. It is also important to conduct a thorough neurologic workup to rule out urinary retention or incomplete bladder emptying. With any hematuria, follow guidelines to rule out associated causes such as bladder cancer, especially in patients with a history of tobacco exposure. We'll continue with our case. On physical examination, Mary's vital signs are within normal limits. Abdominal examination reveals tenderness in the lower abdomen, especially when pressure is applied to the pelvic area. Pelvic examination is positive for tenderness to the urethra and levator muscles. There are no signs of infection or anatomical abnormalities. No fever or signs or systemic illnesses are noted. She scored a 12 on the Interstitial Cystitis Symptom and Problem Index scale. A cystoscopy is indicated when there is a doubt of interstitial cystitis diagnosis, or when there are other conditions that need to be ruled out. An important diagnostic criteria for interstitial cystitis is the presence of Hunter lesions on cystoscopy, since this changes the course of treatment. There are various presentations of Hunter lesions that can be identified in an acute phase as an inflamed, friable area, or in a chronic phase presenting as a blanched or non-bleeding area. Please note that in the absence of Hunter lesions, a cystoscopy will not diagnose interstitial cystitis, but it will help rule out other suspicious diagnoses. A high suspicion of Hunter lesions should be indicated in men and women who present with chronic pelvic pain that is worse with filling, urinary frequency, and a strong urge to urinate. In men, they should be suspected when patients do not respond to treatment of chronic prostatitis or chronic pelvic pain syndrome. Similarly, urodynamic studies are not indicated for the diagnosis of interstitial cystitis, but it can be used to rule out other differentials. Most IC patients will have normal filling pressure and compliance, but pain with filling of the bladder is consistent with the diagnosis. About 12 to 20% will have detrusor overactivity, which complicates the IC diagnosis. If the patient meets the criteria for both conditions, it is reasonable to diagnose them with both. The first step in diagnosing Mary is subsequent urinalysis. Urinalysis, urine HCG, and urine culture were all negative. Urodynamic studies indicated a painful filling phase, but all other findings were normal. Since Mary's urine studies are negative, a cystoscopy is not indicated in this case. A cystoscopy would be indicated for patients over 30 in the presence of microhematuria, which is defined as greater than 2 red blood cells on high-powered field, or gross hematuria. However, note that this is a contested topic, as microscopic hematuria is almost always irrelevant when it comes to evaluating for true genitourinary pathology. Gross hematuria is always relevant, unless diagnosed in the setting of a culture-proven UTI, in which case it can be assessed on a case-by-case basis. In Mary's case, we've ruled out UTI, bladder stones, cancer, and overactive bladder. Now, our interstitial cystitis differential is the most likely diagnosis. And this is where we begin our discussion of treatment and management of this condition. Managing interstitial cystitis is like conducting an orchestra. It necessitates a harmonious collaboration of various medical experts. Primary care physicians must work closely with urologists, pain specialists, and other professionals for comprehensive care, as highlighted in the AUA guidelines. In the realm of treatment, patients compose the melody, while physicians conduct the symphony. Currently, no curative treatments exist for interstitial cystitis. Therefore, the focus is on symptom management and enhancing quality of life. Taking a holistic approach and involving a multidisciplinary healthcare team is paramount. Shared decision-making and informed consent with patients, especially those with chronic conditions like IC, are key to improving outcomes. This complex diagnosis, with an unclear pathophysiology, can be frustrating for both physicians and patients. Education serves as a guide, providing patients with knowledge about their condition, treatment options, and self-care measures. This education transforms patients into active participants in their own care, aligning with the AUA guidelines, which stress the importance of patient enlightenment. Lifestyle recommendations for patients include fluid modification, dietary adjustments to avoid bladder irritants, stress management, meditation, self-care practices, and bladder training. Additionally, it's crucial to consider factors that can exacerbate symptoms, such as constipation, sexual intercourse, tight clothing, and pelvic floor strengthening exercises like Kegels. In the journey toward wellness for interstitial cystitis patients, a multimodal approach is adopted, encompassing behavioral modifications, pain management, procedures, major surgeries, or a combination thereof. When implementing multimodal pain management, various approaches can be explored. Patients can be referred to physical therapy to address pelvic, abdominal, or hip muscle trigger points, muscle contractures, and painful scars or connective tissue restrictions, in addition to pharmacologic and procedural treatments. A typical approach involves a combination of pelvic floor physical therapy, bladder installations, and oral medications such as Urabel, Azo, and Pyrimidine. First-line pharmacological approaches aim to provide pain relief while minimizing side effects. These include urinary analgesics such as pyridium, acetaminophen, NSAIDs, and potentially narcotic medication for breakthrough pain. Refer back to the CDC and AUA guidelines regarding the prescription of narcotics and associated recommendations with their use. The efficacy of these treatments should be monitored and reassessed frequently. Second-line oral pharmacological approaches include amitriptyline, cimetidine, hydroxyzine, and pentosan polysulfate. Pentosan polysulfate, or PPS, is the only FDA-approved oral agent in the treatment of interstitial cystitis and is the most thoroughly studied. However, it is not commonly used in the practice due to the expense of the drug and potential adverse side effects of retinal pigmentary maculopathy and vision-related injuries. If used, discuss the risks of irreversible visual changes due to this medication with your patient and perform a baseline ophthalmologic examination prior to starting this treatment. More invasive approaches require a higher level of care and include intravesical installations of DMSO, heparin, and/or lidocaine, cystoscopy with hydrodistension, intradetrusor Botox A, and neuromodulation. If all treatments fail, major surgery is considered. Botox A is recommended if treatments have not provided adequate improvement. If not performed already, a cystoscopy is considered a second-line approach after bladder installation to determine if Hunter lesions are present. Low-pressure hydrodistension is an option if Hunter lesions are absent. The combination of Botox A and hydrodistension has been shown to significantly improve pain scores and bladder capacity. Currently, neuromodulation is not an FDA-approved treatment and is not as effective for the treatment of pain related to bladder pain syndrome. It is generally only approved for overactive bladder, urgency incontinence, and fecal incontinence. A permanent implant of a neuromodulation device stimulates the sacral or pudendal nerve, which potentially alleviates frequency and urgency symptoms associated with other urinary conditions, such as overactive bladder or urgency incontinence. Surgical approaches, such as substitution cystoplasty or urinary diversion with or without cystectomy, are reserved for complete treatment failures and generally should be avoided. When considered, it is for carefully selected patients with bladder-centric symptoms, or in the rare instance when there is an end-stage small fibrotic bladder. Patient selection has the greatest influence on the efficacy of surgery and management of symptoms, so vigilance in this selection process is vital. Therefore, it is crucial to rule out all other potential sources of pain, such as neuropathic issues and psychological factors, in a primary care setting before considering surgery for a patient with interstitial cystitis. Secondly, we'll discuss the management of IC in a patient that presented with Hunter lesions. Early detection is crucial in this patient to avoid the frustration of failed lifestyle modifications and other treatments, which can prolong time to obtain relief from discomfort and cause undue financial burden. A cystoscopy is such a powerful tool in patients with Hunter lesions. Although their condition can be managed through medications and behavioral changes, the presence of Hunter lesions do indicate the need for a higher level of care, and these patients typically need to be managed by a urologist. The treatment of interstitial cystitis with Hunter lesions is similarly multimodal, but the primary therapy is fulguration with electrocautery and/or intravesical triamcinolone injection. Oral cyclosporin A may be an option for patients with Hunter lesions who fail treatment with fulguration, with or without triamcinolone. In our case with Mary, an appropriate treatment plan includes providing a comprehensive education about interstitial cystitis, its chronicity, and the available treatment options. Mary should also be informed that it's possible for her pain to never completely resolve. This process will take time, patience, and trial and error, but hopefully she will find relief and an improvement in her quality of life. She should also be encouraged to track her symptoms and avoid any triggers: caffeine, alcohol, spicy and acidic foods, and artificial sweeteners. We will also advise her to refrain from doing Kegel exercises, as this can exacerbate symptoms of interstitial cystitis. Pharmacologically, she has not been taking any over-the-counter medications, so we will advise her to start with ibuprofen, acetaminophen, or pyridium. Urabel and vaginal Valium suppositories are also used among urologists to alleviate symptoms. We can also refer Mary to pelvic floor physical therapy to be evaluated and treated for trigger points, muscle contractures, and painful scars or connective tissue restrictions. Additionally, we can discuss bladder installations with Mary. Finally, if these options are not providing her the improvement in quality of life, we can discuss intravesical injections or hydrodistension. The AUA emphasizes the importance of patient understanding and shared decision-making. Inform your patients about normal bladder function and educate them on the chronicity of interstitial cystitis. The diagnosis, treatment, and outcomes are not linear. Work with your patient to encourage them through the process of diagnostic testing trials of various treatments and the intermittent nature of severity of interstitial cystitis symptoms. The landscape of interstitial cystitis is intricate, but we can navigate it with confidence and grace by utilizing the AUA guidelines and evidence-based medicine. Remember that you are not alone in this journey. A network of healthcare professionals stands beside you. By embracing the unknown, advocating for our patients, educating our patients, and applying the principles outlined in the guidelines, we can help our patients find solace and bring their lives back into balance. Thank you for joining me today on this discussion of a complex topic. Together, let us continue to strive for excellence in the care of patients with interstitial cystitis. Keep exploring, keep learning, and keep making a difference.